Hey everyone, welcome to another virtual shadowing session with Hearts for Health. Today we are joined by Dr. Smith. Today we're going to be covering gastrointestinal surgery. Dr. Smith, just to give him a quick introduction, is a gastrointestinal surgeon serving as the Chief of Surgical Services at the VA Long Beach Healthcare System. Dr. Smith has a strong passion for resident education and holds several clinical leadership positions. Just a few reminders for those listening before we do get started. We do have a Q&A, so for those who are new to the general format of our shadowing sessions, you can type in any questions in the YouTube chat and we'll read them out to Dr. Smith at the end of the hour. Towards the last 15 to 10 minutes, we'll cover questions. Other than that, if you want to stay tuned with future shadowing sessions, we roll these out weekly, Thursdays, 7 p.m. Central Standard Time. Just access it through the YouTube page. We live stream it here. And to earn shadowing credit, you must take the quiz. If you'd like to be added to our email listserv where we send announcements over this, then just either subscribe to our website, or you can alternatively email us at shadowing.h and the number 4h@gmail.com and ask to be added onto our listserv for more updates. Other than that, that covers the Q&A, that covers really just the gist of these shadowing sessions. Again, the quiz is going to be available at the end of the session today. You must take that quiz and pass on your first attempt with at least 60%, and you'll be, if you do pass, you'll be forwarded a certificate of completion for this specific shadowing session for 1 hour. But I think that really wraps it up in terms of reminders. So with that said, Dr. Smith, take it away.
All right, good afternoon, and thanks for having me. I'm hopeful that over the next hour or so, I can share a little bit of my own journey and some of my interests that got me here, some of the roadblocks that I had to work around to get here, but more importantly, what a career in gastrointestinal surgery really sort of looks like. My understanding is that the bulk of the folks that are watching this and are interested in hearing about this are people that are still looking at getting into medical school. And that is a long journey. There's absolutely no way to sugarcoat that. I spent a great deal of time in my journey, but persistence pays. And so I would encourage everybody to persevere in their desires. So first and foremost, my current role, I'm a professor of surgery at UC Irvine Medical Center and the general surgery residency program director. We have 6 residents a year here at UC Irvine, and I'm happy to say that we have one of the top programs on the West Coast, as evidenced by the amount of sheer applications that we're receiving these days and the quality of our applicants that we're able to select. So I'm also the co-director of the Minimally Invasive and Bariatric Surgery Fellowship Program here at UC Irvine. It's one of the oldest MIS fellowship programs in existence. We're on our, I want to say maybe our 23rd year or perhaps our 24th year. And I'm a product of that program. I was a fellow here at one point, and then ultimately upon completion was asked to stay on as faculty. And I also serve as the chief of surgery over at the VA in Long Beach. We have a highly integrated service between UC Irvine and VA Long Beach, and our department is very much integrated between the 2 institutions, and our faculty provide service and coverage to our veterans through our relationship with that department over at VA Long Beach. And then finally, I also am the chief surgical consultant for Vision 22, which is in the VA network, which is organized somewhat like a school district, if you will. We have a number of schools within our district. Well, in the VA, we have a number of hospitals within our district, and I sort of serve as the chief surgical consultant for that district, which covers 8 hospitals throughout the southwest corner of the country. So those are my predominant academic and administrative roles. I split my time between the university and the VA, as many VA surgeons do that work for an academic affiliate, such as I do for UC Irvine. And my journey has been a bit of a long one. And sometimes I'm a little bit nervous about sharing it because I don't want to discourage people at how long the journey can be. But there's no way to make it look more attractive than what it is. It's a long, long journey. If you consider 4 years of undergraduate work in college, and then 4 years in medical school, And then in my case, 6 years for general surgery residency, although general surgery residency is 5 years in most institutions, but some programs are 6 and some are 7. So I was at a 6-year program with a mandatory research year, and then a little bit of time in between each of those pit stops. It was a 16-year journey for me, if you count fellowship, in order for me to actually get out and be an attending surgeon. I love what I do, but it was a long journey. That being said, I'm happy to say that I took somewhat of the scenic route to get here. So back in college, I went to college at UC Santa Barbara. Fantastic school, #1 party school. Most of the years I was there, and that comes with some downsides as well. And there was about a year and a half where I didn't do great in college, and my GPA suffered. I think everybody has times where they may not be working to their full potential, and I had that period in college. And I didn't get into medical school during my first round of applications. And as you approach the end of college, it gets harder and harder to bring your GPA up, no matter how well you do. And I had mediocre MCAT scores. They were good, but they were not great. MCAT is the standardized exam one takes to get into medical school, a medical college admission test. And so by the time I didn't get into medical school the first round, I had the options of going on to do a post-bac program, which a lot of people do very successfully, or pivot and consider looking at a foreign alternative. So I was encouraged to go down and look at the Autonomous University of Guadalajara. It is a private medical school in Guadalajara, Mexico, that has a very long-standing and established track record for training U.S. graduates and then repatriating them back to the United States after medical school. And so I chose that route, and it ended up being a really fantastic way to get where I needed to be. I ended up meeting my wife in the process, and so that made for an even more rich experience, and one that I wouldn't trade for anything. I finished up in Guadalajara, and then went through the 5th pathway. That is a route for training that no longer exists. It's been extinguished since then, but it was a way for American medical students who train abroad to then reassimilate back into American medicine. And I did that 1 year at New York Medical College, and then entered the residency match, where my wife and I were fortunate enough to couples match at Harbor UCLA Medical Center down in Torrance, California. That was our #1 choice. And ironically, it was the only hospital where we were both going to be stationed in the same hospital of everything on our list. My wife is a family practitioner, and a superb one at that. And so we did our training at Harbor UCLA. It's a county program taking care of underserved patients. We both really enjoyed that, and got quite a bit out of it. It was a wonderful opportunity to continue to utilize our Spanish skills. And actually, to this day now, more than 15 years out, my wife still takes care of underserved patients at Harbor as an attending physician. Upon finishing my residency training at Harbor, which was a wonderful training opportunity, I did a 1-year fellowship here at UC Irvine in minimally invasive surgery, and loved it, had a fantastic time. And in that time was very productive from a research perspective, and really sort of solidified my desire to be an academic surgeon. And I was asked to stay on as faculty upon completion of my fellowship. And that's when I took on a role predominantly over at the VA. And then a few years later, it sort of shifted back to more of a split between the two institutions. And I'm now approaching my 14th year as an attending. So long road to get here, and it's already been almost as long that I've been out. But in the process, I learned a lot about myself, many things that I certainly didn't know or didn't recognize back at the time. There are a number of different pathways that one can take to get to medical school. Doing fantastic in college, fantastic on standardized exams. Getting right into medical school is probably the most direct route. Maybe even more direct is for a very small and select group of students that are able to get into combined programs, combined undergraduate and medical school programs. Some of those exist throughout the country, and it's usually the most competitive way to get into medical school. After that is just getting in straight after college, but in a separate fashion. For those that don't get in on their first go around, oftentimes students are looking for ways to improve their candidacy as an applicant, make themselves more competitive. So they may go on and get a master's degree or look for some sort of a post-bac program, which sometimes leads to a master's degree and in a few situations does not. But it's additional opportunity for further education in the medical field and provides an additional feather in one's cap, an ability to sort of distinguish oneself from the rest of the enormous pool of folks applying for medical school each year. So, and then there's the foreign alternative. So there's really probably 4 major routes for getting into medical school, I would argue. And everybody really needs to sort of find their way, and they need to take an honest look at their own application. I'm happy to say that when I was in college, my college counselor actually told me I wasn't cut out for a career in medicine and I needed to change careers. And the reason I'm happy to say that is because it motivated me more than ever. And I'm happy to say that I persevered and ultimately was able to prove that I was cut out for a career in medicine. But there will likely be a lot of detractors that tell people you may not be cut out. And sometimes there's some truth to that, and sometimes people are going to be able to overcome those sets of advice, those pieces of advice, and succeed nevertheless. So once one actually does get into medical school, and there are more and more options these days than ever before, far more options than there were back in my day. There are a lot of brand new allopathic medical schools, and there are a lot of new osteopathic medical schools. And so we have a lot more options these days. We're training more people in medical school, but unfortunately, we haven't really addressed the fact that we're not providing additional funding opportunities for more post-medical school training. In other words, resident training, graduate medical education. That funding, it largely comes from CMS, which is Centers for Medicare and Medicaid. And that funding goes to hospitals across the country to help support salaries and payments for residents to actually spend their time learning and training in different specialties. If I'm not mistaken, the last time we had a major increase in funding from Congress, it was back in 1996, and there have been a few little incremental ones here and there. And in fact, there was just a recent increase, a very modest increase in graduate medical education funding that just passed Congress recently. But one could argue that it has not kept pace with the number of medical schools that have opened. So while I think there has become increased access to medical school, there has paradoxically become decreased access to graduate medical education for this very reason. They're not keeping pace with one another. Excuse me. So that being said, many of the competitive specialties in medicine have become increasingly competitive. Take, for example, dermatology, plastic surgery, neurosurgery, ENT, which is ear, nose, and throat. Even OBGYN have all become very competitive specialties. And oftentimes when people don't match in those specialties, particularly the surgical ones that I mentioned, they will either try again the following year or they will pivot and go into general surgery, which has historically been sort of the largest pool of surgery applications and applicants, and training opportunities has been in general surgery. Over the last few years, we've seen a big pivot of folks interested in those subspecialties that haven't been able to get in because of the limited number of spots, then pivot into general surgery. And that has in turn increased the competitiveness of general surgery and is making it somewhat more difficult for the people that have wanted to do general surgery all along to get into a general surgery training program without having spectacular standardized exam scores and spectacular performances in medical school. Much like everything else in life, getting into or getting on to the next step in one's professional life usually depends on grades and a standardized exam. That's usually how you move from high school to college. You have grades and a standardized exam. When you move from college to medical school, you have grades and a standardized exam. When you move from medical school to residency, once again, you have grades and a standardized exam. So with each of those steps, those have historically always been the two common threads. Now, the landscape's changing a little bit. With COVID has brought opportunities for people to apply to college without having a standardized exam score. We have not had any modification in the need for a standardized exam in order to get into medical school. The MCAT is still very much a component of medical college admissions. But we are starting to look at eliminating a standardized exam as a hurdle or a barrier to move from medical school to residency. The National Board of Medical Examiners just this year, actually as of about roughly 2 weeks ago, determined that the U.S. medical licensure exam, step 1, is going to move from a graded exam to a pass-fail exam. And that is dramatically changing the landscape for people to get into residencies in both positive and negative ways. With specialties such as my own, which is general surgery, becoming increasingly more competitive, when you eliminate perhaps one of the very few truly objective measures of somebody's scholastic aptitude, which has long been the U.S. medical licensure exam, it makes it more difficult to separate out good students from amazing students. And almost everybody that graduates from medical school is really smart and really good. And differentiating students can become increasingly challenging as you start to lose some of those objective measures like a standardized exam. On the bright side, for somebody who wants to get into a competitive specialty but may not have had such a spectacular standardized exam score, they now have additional opportunities to not have that eliminate them as a candidate. So there are positives and negatives that come with that. And this upcoming year, as we look at applications for residency starting in the fall of 2022, we will still have applicants that had a numbered U.S. medical licensure exam, USMLE. They will still have had a numbered grade, but the following year, the applicants will have already moved to pass-fail. And so we will have to look at our volume of applications without that data point. So this upcoming year, this current year of 2022, will sort of be our transition year as we start to wean ourselves away from a standardized exam score and really look at all of the other criteria that medical students possess and all of their other characteristics when we're determining their candidacy for residency. So again, it has some positives and negatives, perhaps a bit of a double-edged sword. So that's sort of the road to getting into residency. There is a piece of sorting out where one's passions lie in terms of what specialty within medicine ultimately people choose to pursue. And a lot of students apply for and get into medical school with an idea of wanting to become a certain type of specialist. But oftentimes during medical school, people find that what they thought they were interested in, it actually turns out to not be so much what they're interested in, and they find some other new passion. I think that as we talk about this entire continuum from high school all the way to residency, people oftentimes find that they need to get into something and really experience it in order to figure out where their passions lie, what they love, and what they truly want to do. One of the reasons, if you go back to the most competitive way to get into medical school, which is a combined program out of high school, a combined undergraduate medical school program, which oftentimes is done either in 6, 7, or 8 years, depending on the institution, is that in high school, a lot of students don't quite know yet what they want to do. And one of the advantages to going to college and spending 4 years getting your bachelor's degree is it gives you an opportunity to really try on a number of different careers for size and figure out what suits you. And but for the select few that are superstars and know as early as high school that they want to pursue a career in medicine, the combined route is great because then you don't have to work so hard to compete to get into medical school. You get into this combined program and you move straight through the continuum from high school to medical school. But those are very, very difficult positions to get, and really cream of the crop students, unique students in a variety of ways that have unique life experiences and volunteerism, and have a demonstrated track record of wanting to help others. Oftentimes are the ones that sort of rise to the top of that applicant pool. In college, you have a lot of opportunities to try different things on and figure out whether medicine is actually the career you want to go down. And then once you get into medical school, you get an opportunity to try and to rotate through and try on for size a number of different specialties and figure out what you want to do before you apply for residency. And residency is really where you do your training for your particular specialty. That's where you become a neurologist or a general surgeon or a dermatologist or whatever. Residency is essentially finishing school for a particular specialty. And then if you want to become a super specialist within a specialty, let's say you choose internal medicine, but then you decide that you really like endocrinology within internal medicine, which is a subspecialty of internal medicine, you would then go do a fellowship. A fellowship is really a more specialized, focused super training, if you will, in a particular subspecialty. And there are fellowships in surgery, there's fellowships in medicine, there's fellowships in many different sort of core specialties. And that's where you get a lot of your subspecialty training and really become somebody who's a bit of an expert in their field. Not everybody needs to do fellowships. A lot of people, in fact, I would say the majority of people don't go on to do fellowships, but maintain whatever specialty they ultimately chose while in medical school. But for those that want to become uber specialists, fellowships are how you ultimately obtain that. And so that's sort of an overview of the pathway from high school to becoming an attending physician of some type. And it's a long journey, and there's a number of different ways to get there. Some people take the short road, some people take the medium road, and some people take the long road to get where they want to be. And some people find that they need to apply, not get in, apply again, not get in, and then apply, and then they get in. And so persistence can pay. There's a sizable number of folks that try to get into medical school and ultimately never succeed and went through any one of these routes, and then ultimately decide that they will find a career that makes them happy in some alternative. Which is unfortunate. I think everybody should ideally practice in whatever vocation they are good at and love, and the two often go hand in hand. But the reality is everybody on the planet is not necessarily cut out to be a good physician. And the system sort of sorts itself out, if you will. In terms of what life is like once you finish with residency and fellowship and become an attending physician, there's a number of different settings that you could sort of describe as a generality. Some physicians become academicians, and academicians are usually people that work in a university setting that perform research within their specialty and teach and train the next generation of physicians. And so when you generally do all three of those, that sort of qualifies as an academic setting. Take that in contrast to somebody who finishes residency and just wants to go right out into the community and take care of patients right out of the gates. They don't necessarily want to do research. They don't necessarily want to train trainees or medical students or residents, and they just want to go out and just take care of patients and really focus on their relationship with patients. That is largely called community practice. where you're out in the community providing high quality care directly to your patients. There is a setting that exists sort of in the middle of those, which we often call a hybrid setting. There are a lot of community practices where residents also still rotate for training opportunities. And so you may be a community surgeon where you're interacting directly with your patients on a regular basis, high volume, busy physician. You're not doing research, you're not spending a chunk of your time doing research, but you do train the next generation of physicians. And so those we often call sort of a hybrid approach. It's essentially a community job where you also teach. And a lot of people find their passion in that area because it is particularly rewarding to be able to train and teach and train the next generation of physicians, regardless of the specialty. Not everybody's cut out for that, and not everybody enjoys spending their time that way. But it is a particularly rewarding opportunity and a sizable one. The bulk of physicians, when they're done with their training, go out into community practice. And I would say arguably equal number go into a hybrid setting or an academic setting. And historically, it's folks in the academic setting that really spend some portion of their time doing research. Research can come in a variety of different ways. It may be basic science research, where you're working in a lab, doing basic science experiments and trying to answer relevant medically related questions. It may be research focusing on clinical outcomes. It may be looking at, if you do Operation X on a population and Operation Y on a population, and you compare the outcomes of those two populations to figure out which operation's a better operation. So looking at clinical outcomes or outcomes from variations in clinical practice are ultimately how we fine-tune clinical practice and find better, safer, faster, cheaper, more efficient, more effective, more durable ways to take care of patients. And so there are a whole lot of topics within clinical outcomes research that people often spend their time focusing on and answering clinical questions. There are a lot of things in my day-to-day practice that I don't necessarily know is the best way forward. Or we may have always done something since the dawn of time, but nobody's ever taken the time to stop and study why we do something that way, or study a new approach to figure out, is the new approach better than the old approach? And so that's where clinical outcomes research can be highly effective. That's certainly where the bulk of my passion has been. But basic science researchers, usually at in a university setting, oftentimes are the ones that are making very significant scientific breakthroughs in a lot of different areas, cancer, different research areas. So those basic science researchers are absolutely necessary in order for us to continue to move science, and in particular move medicine forward. So how one ultimately decides what type of a practice they're going to participate in when they finish residency really kind of depends on which of those settings is the most appealing. And sometimes job opportunities may ultimately dictate as well. It may also be dictated by geography. If one wants to move back to Anchorage, Alaska, which is where somebody grew up and that's where they want to practice, you may have to look at what the opportunities there are at the time. And so sometimes the needs of the community will dictate as much of how you practice and what you do as much as anything else. I'll use my own specialty as an example. I'm a broadly trained general surgeon who then did a fellowship in minimally invasive and laparoscopic surgery. Now, I, as a general surgeon, if I chose to go work in a very rural town, a rural small town in Montana, where medical services are more scarce, I would probably have a wider breadth of practice and do more within my scope of practice than if I am practicing in downtown LA, where there are surgeons on every corner and everybody is super specialized. It would be harder and harder for me to be able to maintain a very broad practice in an environment where there are a lot of physicians. So I oftentimes tell my trainees and my residents, one of the beauties about general surgery is we're going to train you to be to be able to do a whole lot of different things. Which of those you actually end up doing in practice will depend a lot on the needs of your community and where you choose to practice. And so if you want a broad practice and you want to be doing true broad scope of procedures, don't go work in a huge metropolitan area where there are lots and lots of surgeons. You need to probably focus on providing your services to a smaller community where you may not have an OBGYN readily available. So the general surgeon needs to be able to provide some rudimentary OBGYN services. And that's just one example. So there's also a component, not just of your training in terms of what your practice is going to look like, but also the component of where you choose to practice and what the needs of your community look like. So those are some things that I think folks, when they're in residency, need to start paying attention to and thinking about and focusing on. And at the end of the day, people make a lot of decisions based on geography. They either want to live close to family or live in major metropolitan areas or live in a more rural environment away from the city. And so there are a lot of geography factors that are often taken into account when people are looking for jobs. And then there's always the component of timing. You may be looking for a particular type of job in a particular environment, but if the timing's not right, there's not a need at that time, you may have to settle for something else or somewhere else. And bide your time and wait until those opportunities come up. So these are multiple layers of complexity that are compounded on top of everything else I've already talked to you about in terms of deciding or determining what your scope of practice within your specialty ultimately looks like in your day-to-day professional life. And so if hopefully it is as clear as mud how you get from point A to point Z in the course of one's career. I'm happy to say that here in my environment at UCI and over at the VA, I am a super specialist here at the university. And then a few days a week when I'm at the VA, I'm a real generalist. So I love the split duties because I have the best of both worlds. I don't have to be a generalist. I don't have to be a super specialist. I get to sort of be a step into a different pair of shoes depending on which day of the week it is. And so it really is the best of both worlds. When you become a super specialist, you become fantastic at a smaller array of things, but you lose the ability to have as much variety in your practice. And so that's a piece that people have to think about and ultimately determine when they're in residency and they have to decide whether they want to go into fellowship training and become more specialized, or do they want to remain a real generalist and take care of a lot of different disease conditions. So trying to think if there's anything else I want to mention as far as sort of getting to the end point in one's career. There are also cases here and there where somebody chooses a specialty and gets trained and gets out and practices in that specialty for a while and may ultimately decide to go back and do something differently. I've had a few residents over the years that had a career in one specialty and then decided they wanted to come back, wanted to be a general surgeon, and have come back and are starting general surgery over, or have started general surgery over from scratch. And then do a totally different training route. In other words, you get trained in a couple of different specialties. It's a long and grueling process, and not very many people do that, but some do. And for the ultra ambitious ones, they may ultimately end up being a specialist in two somewhat different specialties. So, but practically, from a practical perspective, practicing in both of those specialties at the same time, it rarely occurs unless one works in a more rural environment where resources are more scarce. And both of those sets of skills are needed. So with that, I have talked a long time. I'm happy to open up the floor and provide people some opportunity for feedback or questions.
Definitely. We've had quite a few questions roll in. Overall, to begin with, very, very informative, very, very insightful, especially for the population of pre-med, pre-health students in general who might not be as acclimated to the general understanding of what is residency to begin with, what is fellowship, what are the different kinds, how do you go about untraditional routes, to mention a few of them,
Mhm.
And it's great to have your expertise on board here to educate the students we have, especially being so early on. Using this advice is definitely going to be great leverage for later on. So let's get to the questions we have. We have quite a few. The first of which is a student asking, how did you stay motivated during your process, even when people did tell you, just like you mentioned with your advisor, that maybe you should pick a different career path?
I think it's easy if you can't find an alternative that excites you more than the path you're chasing down. If there's another path where you're thinking about and everyone's telling you, well, don't stop trying down the path that you're on, I think it's a little easier to pivot. It's easier to stay motivated if you really haven't found any other passions or things that you want to pursue. So in my own case, my motivation largely came from the fact that I had looked into a couple of other career options. I was originally at one point going to be an engineer, and at one point I had the realization that that was not going to make me happy, and I didn't love it. And ultimately, I decided I wanted to help other people. I wanted to help improve the life of other people, and provide service to other people, which is easy to do in medicine, very easy to do. So those things kind of helped keep me focused and persistent. And at some point, I started to have some wins and some progress and some success. So it was easier to put the detractors behind me and keep moving forward.
Our next question is another student asking, do you know what the route is now if you do want to study medicine abroad? So for example, there's obviously Caribbean medical schools, Ross University, St. George's, etc. But maybe I've heard of a few people studying in Israel or Italy, and then maybe going back to the US. So overall, they're just asking, what would the route look like? If they want to study medicine abroad, do you recommend it, or is it better to stick with US med schools?
I think you have to take a critical look at your own application, your candidacy, your suitability for entrance into a U.S. medical school. And if you can't judge the quality of your application yourself, you probably need to go ask some others for some advice. I think foreign options are actually a very reasonable way to go. It worked very well for me. But I had a little bit of a more established pathway that I took. In the current day and age, if one wants to go train outside of the country, there are a ton of options down in the Caribbean, Ireland, Israel. It's almost an unlimited number of options outside of the country for either foreign medical students trained in foreign medical schools to come to the United States, get trained, and go home to their home countries to provide medical care in their own countries, or for American grads to go outside the country, get trained, and come back to the United States. It's called ECFMG, the Educational Commission for Foreign Medical Graduates, is the conduit for people, for foreign trained physicians to get to integrate and assimilate into the US medicine training system. So ECFMG is really the conduit these days, and the only one that I'm aware of that would allow people to ultimately be able to apply for a US residency program.
Going back to your journey, we have a student asking about what you would do if you were able to turn back time, and just go through this process all over again with the knowledge that you know now. Would you choose to study abroad during your undergraduate years?
During my undergraduate years, I did not study abroad. Would I choose to do so? Yeah, perhaps. It was just never something I had strongly considered or found much value in. But I think now, as somebody who is more of a world traveler now than I was back then, it's easy for me to say, yeah, I absolutely would have incorporated that into college. Now, would I take the same route as far as a foreign option for medical school? Absolutely. I wouldn't change anything, because if anything in my path had led me down a different road, I wouldn't be right where I'm at. And so at some point, one often realizes that your failures or your obstacles that you run into can be very frustrating at the time, but once you eventually move past those and you get to a point of success, you'll look back and realize that the only reason you got there is because of the route you took. And it becomes much easier to accept that failures, roadblocks, no's oftentimes lead you down a different route, and there are a lot of routes to happiness.
Yeah, that actually brings us back to, we had an earlier speaker just a few weeks ago who mentioned a very similar point. He was in the process of applying to med school, but he got the acceptance, and the only thing preventing him from going on was the lack of immunization records he had. I don't think it was either that he didn't have the immunizations or he didn't have the records available. And then he ended up taking that year off because he was not able to go on medical school, but he ended up doing a master's in public health, and that thrived into something more later on into his career. So I guess all in all, we can say that the failures we do have might turn into the best successes later on. So definitely some great insight there.
I've often told people from your greatest disappointments often come your greatest opportunities.
Yeah, definitely. That's a quote to keep in mind. Did you ever consider any other career paths, maybe still in the health professions, including, like, let's say, physical therapy? There's a few others out there, nurse practitioning, etc. And if you did, what made you decide what you ended up doing in medicine?
I really didn't consider any alternatives, but now that I have some experience under my belt, I have a daughter in college right now who is considering a career in medicine. I haven't pushed her into it at all. I've really tried to let her find her own way. But in the process of doing so, I have tried to help open her eyes to some additional opportunities. Nobody in my family had ever gone to college. And so I was a first generation college grad. I did not have any mentorship. I did not have much advice at all. And so I'm trying to do better for my daughter by opening her eyes to a lot of other opportunities. Physician's assistants are absolutely critical, physician extenders. Nurse practitioners have almost as much ability to write prescriptions, treat patients, and function autonomously, depending on which state you work in, as physicians do. And it's a much shorter training and career path. And so there are so many opportunities within medicine to help patients and help people and find one's career to be very fulfilling. And whether that be from helping others or seeing people get rehabilitated back into a more functional state, at the end of the day, you can help people in so many different ways. And there's a ton of opportunities within medicine. I did not consider many of those, but I strongly encourage people that are looking at medical school to consider perhaps some of the alternatives that are shorter training paths, less expensive, and oftentimes can lead to a very fulfilling career.
What kind of medical service work were you and your wife doing when you were in that reassimilation year you mentioned earlier, and you had returned back from medical training abroad?
The Fifth Pathway program back in the day was essentially doing one's third year medical school over again. You rotated through the core rotations, the big 6 rotations: psychiatry, internal medicine, surgery, OBGYN, family medicine, and what am I missing? Did I mention psychiatry? So the big core rotations, which are what people predominantly spend the third year of medical school doing, the Fifth Pathway program took American citizens who trained abroad, brought them back through that program to make sure that they were sort of up to snuff with their training, and then fed them on into residency applications. And so it was essentially third year medical school over again. So I spent 1 extra year in medical school for all intents and purposes. Yes, tuition extra.
Yeah, definitely. Going back to your undergraduate years, we have a student asking, what type of patient care activities or just in general clinical experience did you have? Definitely at this time now, that's a concern for many, and it's still a priority for medical schools, obviously, because we're getting ourselves involved in a hospital-centered, clinic-centered role. So clinical experience is obviously going to be at the top of the list in terms of priorities. However, with the pandemic, that's obviously become more of a hurdle. But going back to your undergraduate years, what were the activities you did? Do you have any advice for those who are seeking hours at this point?
So shadowing physicians is critically important. I always tell even medical students, even students that have already got into medical school, I often highly recommend that they spend time shadowing physicians. Back as early as, gosh, I want to say probably my junior year in high school, I would shadow a surgeon And I had a family practitioner that I would go spend the day with and basically just hang on their coattails. First year of medical school, I did a lot more shadowing. Like when I would come home on vacation, I would spend time shadowing physicians. I wanted to kind of see what a day in their life looked like. And that's critically important because being an orthopedic surgeon may sound fantastic, but you go spend a day with them and perhaps it's not quite what you thought it was going to be. They don't have as much time in clinic. And take, for example, orthopedic surgery and compare it to ENT or urology. The proportion of time that orthopedic surgeons spend in the operating room fixing things and the amount relative to the amount of time they spend in clinic is much, much higher. Whereas ENT and urology oftentimes do a lot of procedural care in clinics. So they're in the office seeing patients, but doing procedures in office and less time in the operating room as a generalization than say an orthopedic surgeon. So many of the surgical specialties have a variable layout in terms of time spent in the office seeing patients directly versus time in the operating room versus time taking care of patients in the hospital or inpatients. And so oftentimes people choose a surgical specialty kind of based on that balance. And so from my shadowing experience, I learned that I really liked being able to see patients in clinic. There was a point in time where I wanted to be a family practitioner because I loved the idea of having patients that I knew really well and had a longstanding relationship with over many years. Well, I came to realize that I could be a general surgeon and operate and fix things, but still have a longstanding relationship with many of my patient populations. My cancer patients, I follow for 5 years. My bariatric patients, I follow indefinitely. My acid reflux patients, I follow them yearly. So I do have a lot of continuity, even though I think many people assume that a surgeon just fixes things and sends the patient on down the road. But I actually have the best of both worlds. And I love I love the balance between operating and spending time in clinic with patients. So shadowing is a really wonderful way to truly get an opportunity to see what that balance looks like for a particular specialist. And you can do that as an undergraduate, you can do that as a medical student. Physicians almost anywhere are usually very happy to have people shadow them and sort of see what things look like. I actually spent a summer in college as essentially an engineering intern and to try on engineering for size. And halfway through the summer, I got laid off because the economy was terrible. And I realized that one of the things I didn't love about engineering was that it was a profession that was largely dependent on the economy. And that was one of many reasons I came to realize that wasn't what I wanted to do. So people have to try on a lot of different things for size.
I think you mentioned it there leading into this next question here, but a student was asking, with the whole gist of being a surgeon, there's the stereotype of, you're limited on hours, you're on call frequently. In general, your work-life balance is more or less controlled by the work side rather than the personal life side, in comparison to specialties like dermatology, ophthalmology, etc. So with your experience over the years, has being a surgeon limited your personal life? In other words, is the work-life balance for surgeons actually as bad as it is portrayed in the stereotypes that many people bring up?
I think one's work-life balance is what they make of it. I would say that's probably 75% of it. And the other 25% of it is, where did you take a job and in what specialty? Those two factors probably make up the other 25%. I'll tell you what I mean by that. If you decide you're going to take a job as a general surgeon in a practice of 2 surgeons, and you guys are the only ones that service your entire community, you're going to be on call 50% of the time. And whereas if you join a large group in a major metropolitan area where there are other groups that you're competing with, you may take call a couple times a month. Call is oftentimes a big impact on one's quality of life. And I'm happy to say that I'm in a large group at the university, I'm in a large group at the VA. And so call is really very, very manageable for me. The other thing that I often really want to, the point I want to drive home to anybody applying to any specialty is that we, regardless of what specialty you choose, spend a lot of time at work. And if you choose a specialty based on what you perceive the lifestyle to be, but you go to work and you're not inspired by what you do, that is a real shame and a waste given the amount of time, money, and energy it takes to become a physician. I always encourage everybody to start with a specialty that inspires you, something that you have a passion for. And if neurosurgery, which is often very busy and very demanding, is something you love, but you really want to maintain a good work-life balance, then you go train to be a neurosurgeon, and then you join a big practice in a major metropolitan area where there are other neurosurgeons around and you guys help each other. You don't go move to small town Indiana and become the only neurosurgeon in town. So a lot of it depends on, once again, the needs of your community, the type of practice you join, the specialty you're in. I have always found a wonderful balance. But I started with something I love, which is being a surgeon and fixing things, helping people feel better by fixing their ailments. And I've started with that, and I have ended up in a career, not coincidentally, that happens to have a very good work-life balance. And so you can have it both ways. And I really encourage people to shoot for that and not try to pick a specialty that doesn't inspire them just so that they can be home at 5 o'clock. You can be home at 7 o'clock and still love what you do. You can be home at 3 o'clock and still hate what you do. So at the end of the day, you have to follow your passion, and then you sort out the job market, the environment, the geography that suit your work-life balance.
Definitely a lot of insight there. And I think, if you're chasing what your passion is, if that's where your passion lies, I don't think the hours would be necessarily much of a nuisance, really, because that's what you love to do. That's what you love to work for, just like you mentioned there. So another question we have is around experiences, although particularly research experience for undergrad. So what's the best way that you've seen to start getting involved in research? The student here is asking, preferably in a lab setting.
So at almost any college, there are tons of opportunities to get involved with research. When I first started as an undergrad, I remember days working in a lab with a PhD student who was studying the chirps of a cowbird. And we would sit there and listen to recorded noises of the different chirps of a cowbird and try to figure out what they meant. There's an infinite number of ways that one can get involved in research. And I would encourage people to try to find projects or researchers that are doing things that are interesting to them. Otherwise, it's really just sort of an activity, a bit of futility for the sake of improving one's CV, which doesn't make a lot of sense. Research is about answering unanswered questions. That's the purpose of research. That's why we study things, is so that we're constantly getting better. We're constantly finding a better way to do things. We're constantly making new discoveries for the sake of the betterment of humanity. And so people need to try to look for opportunities that kind of sync with things that they think they're interested in. Even if you end up doing a research project and find that that's something you're not interested in, you learned something from that. You learned what you're not interested in. But you don't know that until you actively try it on for size and really get into that field and do that work. So across college campuses, almost anywhere you go, there are research opportunities, people doing one type or another, and you got to reach out and talk to people. I would say the PhD students at almost any college usually have some research going on that they're happy to have undergraduates help them with. In medical school, there's almost an infinite number of research opportunities across the School of Medicine that people can get involved in. And so you got to look at what your local resources look like and find a menu and get involved with something that reach out to people, be tenacious and be ambitious, make that effort to reach out. And people are usually thrilled to have research assistants.
We have a similar question to this. I'm sure really much of what you mentioned there will cross over and apply here. It's really just over how students in a similar case would get experience, although for shadowing, like you mentioned, with clinical experience, that's important, although medical schools sometimes draw the line between clinical experience and shadowing, but in one way or another, it's exposure. And they're particularly asking because of the general pandemic, especially with the recent surge. I want to maybe add in that virtual shadowing, it is there, although, the discrepancies over how it's going to be thought of by different medical schools may be different and varying, although it can be counted for and hours are credited.
Mhm.
Any different comments around that specifically for shadowing?
It's clear that the pandemic put a lot of people at a disadvantage because it shut down our ability to have people in person shadowing us. I've almost always got a medical student, an undergrad, or somebody with me, whether I'm in the operating room or in clinic. And that has largely been curtailed due to COVID, just kind of getting ready to open. And then we ran into the Omicron surge, which is now starting to kind of settle down. So fingers crossed that we are within the next few months going to get back to some sense of normalcy and kind of be able to get back to business as usual. Virtual shadowing is better than nothing, but I definitely think it's a disadvantage to being in person because you're not seeing my patient with me. You're not in the operating room with me, directly watching what we're doing. I think it is a surrogate. It's not an ideal one. It's better than nothing. But I'm more focused on our ability to kind of move back towards a little bit of a sense of normalcy so people can get back to doing this in person. It's critically important.
Yeah, definitely. And as we wrap up the hour, maybe we can go for one more question. So you mentioned a few untraditional paths to the general pathway, the journey of completing medical training from high school, undergrad, medical school, and even residency, even fellowship, if someone does try to pursue that. I'm not sure if this was already covered, but in terms of someone who say they've done residency, say we'll throw out the example of maybe an OB who's done residency, they've been out of practice or they've been out of training for 3 years, they've been practicing since then, and then they decide, hey, I want to go back into fellowship for a certain subspecialty because they've gained an interest for that. Maybe they've seen a few colleagues who've done some great work on that frontier.
Mhm.
How would they usually go about that? What are the common hurdles they face?
So let's say you are out and trained and completely doing OBGYN as a career, and now you want to go back and become subspecialized. Your options are only fellowships that fall underneath of the umbrella of OBGYN. You can't go back and do a vascular fellowship because the prerequisites to do vascular haven't been met, which are basically under the umbrella of general surgery. So every fellowship kind of falls under an umbrella of a larger, more general specialty. If you, as an OBGYN, decide you want to become a vascular surgeon, you have to go back and do your training as a general surgeon and then your fellowship as a vascular surgeon. So you're somewhat limited in terms of what your fellowship opportunities are that you can reapply for. It needs to be something that has OBGYN as a prerequisite. Otherwise, you're starting from scratch at the beginning of a brand new residency. And residency is hard. It's some of the hardest years of your life. Some of the best years of your life, but they're tough. And it doesn't matter what specialty you're doing your residency training in. It's tough. They are really tough years.
All right. Well, I think that's a good point to end off on. That will really wrap up today's session. Thank you so much, Dr. Smith, for joining us. It's really been a joy and very, very insightful, especially for this group of students here. This is going to be extremely insightful and definitely it fills a gap that a lot of people might have in terms of their understanding of the whole process. We understand what we might have here with medical school applications immediately following undergrad or maybe a few years after, but later on along the road with residency fellowship, not much is known for the pre-med, for the pre-health population. So we're really appreciative of your time and your insight into that.
Well, thank you for having me. I appreciate it. And I good luck to everybody out there who is following this path. But keep in mind, not everybody needs to be a physician to be happy. There are so many other related careers in medicine where you can still help people and have a very meaningful, fulfilling career.
Mm-hmm. Yeah, definitely. Just a few last notes for those listening in. We have our quiz out. We send it over through the YouTube chat and also on our virtual shouting page. You can access it either way. It's the same quiz. Just fill it out, at least 60% to pass it on your first attempt. And if you do, you'll have your certificate sent to your inbox of the email address you listed on the quiz. If you don't find your certificate in your inbox, check your spam folder. Although if that doesn't work, feel free to email us and we can help out with that. Another quick note, the quiz will be due next week on this upcoming Wednesday, February 9th at 11:59 p.m. Central Standard Time. I think that really wraps it up in terms of a few last reminders. For our next shouting session next week, we're going to have it same time, Thursday, 7 p.m. Central, February 10th with Dr. Wender. We'll be covering community health and family medicine. So another specialty there. And I think that really will wrap it up. So again, thank you so much, Dr. Smith, for taking time to join us today, and hope everyone has a great night.
Thanks, Michael. Take care.